Bit harsh in the start. So, you agree? He agrees very quickly because he was in. It is a medium vessel vasculitis. Okay, medium vessel. So it is a systemic vasculitis which involves the small and medium sized. But instead of it's also involving the medium as well as the small. So it goes. There is an overlap now. From the medium, it involves the small vessels also. Yeah. So the large cell they involve the medium, and sometimes the large cell will involve large vessels will involve the small also, like the giant cell. But the medium in polyarthritis nodosa, it involves the medium as well as the small. The Kawasaki involves the medium and the large. Reversal. Kawasaki medium and large. Polyarthritis nodosa medium and the small. So it involves the renal and the visceral vessels. All the vessels here. Renal and the visceral. But it spares the pulmonary vessels. It spares. So pulmonary vessels are not involved in polyarthritis. Typically they are not involved. Sometimes, very rarely they can be involved. So if you are asked a question, what are the vessels which are not involved in polyarthritis nodosa? They are the pulmonary vessels. So if I emphasize something, it means it is important. And 1/3, what is the cause? 1/3 of the patients, they are having hepatitis B. Okay? So it means immune complexes are formed. Hepatitis B antigen, hepatitis B antibody, and these deposits. Only in 1/3. But cause in others is unknown. Where this disease happens? It happens in the young adults, and it is present in all the age groups. All the age groups. How it presents? Acutely or chronic and episodic. There is some episode, then there is symptom-free interval. Then again the episode occurs. Then again symptom-free. This is how it happens. But classical presentation. So all these diseases can present variably. Sometimes mild symptoms, sometimes severe symptoms. But there is classic presentation. Classic presentation. What it is? Rapidly accelerating hypertension. Very quickly there is hypertension. Rapidly accelerating. Abdominal pain and bloody stools. Because it is involving the renal and visceral. So renal, you can have hypertension. Visceral vessels, you can have abdominal pain, bloody stools, muscular pains also, and if it involves the nerves also, peripheral neuritis. Mostly the motor. Okay? And renal involvement is a major cause of death because it leads to rapidly accelerating hypertension and it can cause death. Untreated, if you do not treat PAN, it is very dangerous. It is fatal. It will kill the person. Okay? But if you treat it with immunosuppression, you can have cure in 90% of the cases. Remission or cure in 90%.
Can doctor spread to the large one?
No, it is
because it's in the middle. It can large.
No, it is for medium and small. It is for medium and small. Okay? It is confined to that.
Doctor, what's the relation with the infection? We said
immune complexes.
Second.
Immune complex will be formed and it will attack. Okay? But cause in others is unknown. Only 1/3 have the chronic hepatitis B infection. So what is the morphology? You know, the kidney, heart, liver, vessels, all the vessels in the viscera and the renal vessels can be involved. So polyarthritis nodosa. Okay? Polyarthritis. Many arteries, medium and small arteries. Acute phase, you will have transmural inflammation, mixed. So you can have acute inflammation as well as the chronic. Along with necrosis. Fibrinoid necrosis, you know the type of necrosis, fibrinoid necrosis. So you will have mixed inflammation, acute and chronic, along with fibrinoid necrosis of the vessel wall, along with thrombosis in the vessel. Along with thrombosis in the vessel. So mixed inflammation, fibrinoid necrosis and thrombosis. Three things will be there. And older lesions will lead to fibrous thickening of the wall. Clear? When they are healing. And all the stages of activity. It is not, here the importance of the PAN is some vessels you will find having acute inflammation, some vessels chronic, some vessels healing. So you can find all the stages of the disease in the same person, even in the same vessel. In the same vessel, some part is showing acute, some chronic, some healing. So all the stages of activity can coexist. And ulcerations, infarcts, ischemic atrophy, hemorrhage, aneurysms and rupture can occur because of damage to the wall.
Yes.
This is the simple. Damage to the wall can lead to aneurysm, weakening of the wall. Aneurysm and followed by rupture. Huh? Or it can lead to infarct, ischemic atrophy, fibrous thickening. So all the things can be there.
There is no necrosis in other type.
Other?
Types.
You mean five,
No, fibrinoid necrosis here in polyarthritis. There is necrosis, fibrinoid necrosis, but necrosis is there.
Yes.
But here it is fibrinoid necrosis. Fibrin exudation. Is it clear? Polyarthritis nodosa?
Yes.
Anything you want?
Thank you.
Which type of thank you said?
Thank you for both of
Not
them.
done the
No, you have noted. Kawasaki disease, another medium vessel vasculitis. Kawasaki disease. So it is present mostly in the infants and children. Okay? Infants and small children. Affects the medium vessel and the large vessel.
Yes.
So here medium and large. Polyarthritis small and medium. Clear?
Yes.
So typically how it presents? Its presentation, the child will come to you, infant or child. He will be having these areas, erythema of the conjunctiva, oral erythema, edema of the hands, feet, okay? Hands and feet, edema will be there. And he will have a rash, desquamative rash, and he will have cervical lymphadenopathy. So when you find these features, you call it as mucocutaneous lymph node syndrome. Mucocutaneous lymph node syndrome. There is enlargement of the lymph nodes, mucosa is involved, skin is involved by rash. So all the three things, mucocutaneous lymph node syndrome. So this is another name for Kawasaki disease. Okay? Another name. What is the clinical significance? Although the patient presents like this, the clinical significance of the Kawasaki, you have to treat it. Because sometimes the coronary arteries are involved. When the coronary arteries are involved, it will damage the coronary artery. There can be ectasia, abnormal dilatation, or aneurysm. Aneurysm of the coronary artery, which is very big, 7 to 8 mm. And it can rupture this aneurysm. If it will rupture or undergo thrombosis, it will lead to myocardial infarction. So you will find myocardial infarction in a small child, and he can die from this. Huh? So this is, sometimes you find myocardial infarction in small child. One of the causes can be Kawasaki disease. If you diagnose it, treat it. Again, how you treat it? You give the immunoglobulin therapy because it is involving the anti-endothelial antibody. Okay? So you give the immunoglobulin therapy and aspirin, and you can reduce the coronary artery disease to about 4%. Still it will be there. Even if you treat it, but it will be reduced. Okay? It will be reduced to 4%. Otherwise it is around, I think, 20 or 25%. What is the pathogenesis? Again, in small children, viral infections are very important. Isn't it? More common also. So it is mostly, initiated by the infection. Mostly the viral infections. And this is the delayed type of hypersensitivity. What happens first? There is delayed hypersensitivity against some cross-reactive or newly uncovered vascular antigen. Subsequent cytokine production. You know how the antibodies are formed. It always starts from the T cells.
Yes,
You have to
sir.
remember this. So that is why we say this is delayed type of hypersensitivity. T cells get activated. These T cells secrete the cytokines, okay, and it activates the B cell. This B cell now forms the anti-endothelial cell antibodies, which are important in this disease. You got it? But it starts from the delayed type hypersensitivity. Clear?
Yeah.
So when these antibodies are formed, they will attack the endothelial cells and they will attack the smooth muscle cells. Okay? This is the pathogenesis of the disease. And morphology, you will find a dense transmural infiltrate throughout the vessel wall. And fibrinoid necrosis can be present in this also, but it is less prominent than in the pan. It is less prominent than in the pan. And heel lesions, they will obstruct the vessels. So this was the Kawasaki. It is also known as mucocutaneous lymph node syndrome. And coronary arteries may be involved. So this finishes the medium vessel. Now remains the small vessel vasculitis. So small vessel vasculitis, if you can take the permission, but what you will say to me? What you will say to doctor?
Yes, sir.
So here, I am not that old. Older people, you play the tricks and other things also, no? But here I am not that old, so I will not. tricks and many things I have seen. Doctor, I tell you the name. I see in the clinical script most of the times. What is his name? Dr. Mustafa. Polyangiitis. So we will be discussing 3 diseases. Microscopic polyangiitis 1. It is also known as hypersensitivity vasculitis or leukocytoplastic vasculitis. Another is Wagner's. Another is Churg-Strauss syndrome. Okay. This is a bit dry subject, but if you try to understand and read it today, you will remember. If you don't read it today, you will not. It's very difficult. I have tried to minimize the content and make it easy, but the thing is that it's an important one, so I cannot reduce the content also.
Okay.
If you are planning for the USMLE, you will get questions. So this is important from that aspect also. We have to see everything. That's why I have increased the content from the last lecture. Because in the last lecture, many important things were missing, like pulseless disease. It was not written there. So if you miss that, so it should not be. So what is microscopic polyangiitis? Microscopic. If you hear the name, even if you forget, microscopic means small vessels.
Yes.
Okay? Arterioles, venules, and capillaries. You have the arterioles, you have the venules, not the veins, not the arteries. Arterioles, venules, and the capillaries. And one thing is important here, all the lesions tend to be of the same age. In PAN you have some acute, some chronic, some mild.
Mixed.
Many stages. But here, if you find one lesion in one vessel, the other lesion will also be of the same age. So this is the difference between the microscopic and the polyarteritis nodosa. And here you will find all the things involved. Lungs, GIT, kidneys, everything. But the important is, the PAN doesn't involve the pulmonary, it involves. This is another importance, okay? And necrotizing glomerulonephritis, you will see in 90% of the cases, and pulmonary capillaritis is also found. So here, the pulmonary or the lung is involved. And how the patient will present? Lungs are involved, hemoptysis. Renal is involved, hematuria, proteinuria. Vessels, visceral vessels are involved, abdominal pain and bleeding. Muscle pain. Skin is involved, cutaneous purpura. And how you treat it? Immunosuppression. Or if you know of the offending agent, you remove the offending agent. And it will lead to remission. But once it involves the kidneys and the CNS, then the remission is, a bit difficult. So you will not be able to induce the remission time. So you have to do it very fast. Yes.
This is one of the rarely things we can locate or indicate the agent or antigen.
Here,
Yes.
I will tell you in the pathogenesis. If you go for the pathogenesis, see. This type of vasculitis, which involves the small vessels, it is seen because of some drugs like penicillin. It is seen because of some bacteria like streptococci, because of tumor proteins, because of heterologous proteins. And it is also seen in some immune complex diseases. Inox-Schönlein purpura, cryoglobulinemia, and connective tissue disorders. Okay? You have the connective tissue disorder. Because of that, the person has the vasculitis. Huh? So it is seen in a variety of conditions. Suppose if it is due to the infection, you remove the infection.
Yes.
It is due to the drug. You remove the offending drug, so you will have the remission in the patient. Okay? So if you have the offending agent, you have to remove it. So you will have the remission. Here we say both the immune complexes can be involved or the antibodies can be involved. Which antibody? ANCA. Okay? But most of the cases are associated with MPO ANCA. Or the, which ANCA? P ANCA. P ANCA or MPO ANCA. Okay? Myeloperoxidase ANCA. Yeah. So here the microscopic polyangiitis is associated with MPO ANCA. Okay? MPO ANCA. And what happens? ANCAs, they will lead to neutrophils. Neutrophils will be attacked and then they will release their contents and they will injure the endothelium of the vessel. So this is microscopic polyangiitis. What is the morphology? It will lead to segmental fibrinoid necrosis. Again there will be necrosis of the media with focal transmural necrotizing lesions, and granulomatous inflammation is absent. Here you will not find the granulomatous inflammation. But transmural inflammation will be there along with the fibrinoid necrosis. Lesions resemble the PAN. In PAN also you find necrosis. In PAN also inflammation is there. But it spares the medium and the large arteries. So PAN can involve the medium arteries,
Yes.
but it doesn't involve. It is microscopic only the smaller arteries. No, infiltrating neutrophils frequently undergo. I will show you the diagram for this. When the neutrophils are infiltrating the wall of the vessels, they undergo fragmentation. This is known as leukocytoclasia. What? The neutrophils, when they are entering the vessel wall from the blood, they undergo fragmentation, they break. And this breakage is called as leukocytoclasia. That is why it is also known as leukocytoplastic vasculitis. This is the reason. So this is another name for microscopic polyangiitis, and it mostly occurs in the post-capillary venues. Post-capillary venues. Here also, early skin lesions can show the presence of immunoglobulin and complement, but most of the lesions are pauci-immune. Because they are associated with ANCA, so they are pauci-immune, because they are directed against the granules of the neutrophils. So this is microscopic polyangiitis is finished. The next is Wagner's granulomatosis. So this is a small vessel vasculitis which is having granulomas. Name granulomatosis. So microscopic polyangiitis doesn't have the granuloma. So if you find small vessel inflammation, no granuloma, mostly microscopic polyangiitis. Granuloma present. But not only granuloma, it has a characteristic involvement. There is necrotizing vasculitis, but it has three features. Triad. Triad is there. It involves the lung and the upper respiratory tract. Lung and the upper respiratory tract. I will show you how. Then it will cause vasculitis. So you will find granuloma 1, granuloma in the lung and the upper respiratory tract. Vasculitis of the small to medium sized vessels. Okay, small to medium sized in the lungs and the upper respiratory tract. So in the lungs and the upper respiratory tract, you will find vasculitis, inflammation of the vessel. You will find granulomas. Two things will be there. And in the renal, you will find glomerulonephritis. So mostly it involves the renal and the respiratory tract.
He said no.
Also problem?
Yeah. Also, his lecture next week, I make it this week.
Not. So next, then obviously there will be no problem. So you got it? So I will finish this one and we will finish the lab also. I didn't want it, but you people. So kidneys are involved and the lungs and the upper respiratory tract. So you will find the inflammation of the vessels as well as the granulomas in all these cases. So limited, but there are some limited forms of the vaginal granulomatosis. What are the limited forms? They only respiratory tract. But there is a widespread form which involve the other vessels also, like of the heart, of the eye, of the skin. So you can have a limited form of vaginal granulomatosis, you can have a widespread form, or you can have the classical form. Classical form, lungs and kidneys. Limited, only the lungs. And widespread can involve the other organs also. How this vaginal granulomatosis? Again, if you have the granulomas, it is cell-mediated hypersensitivity. Very simple. Granulomas are present, cell-mediated hypersensitivity. Again, some infectious agent or the environmental agents, we don't know. We are not sure what is the antigen. As I said in the beginning, the specific antigen is not known. It is unknown. And what you will find in vaginals, you will find PR3 ANCA in almost 95%. So MPO ANCA in microscopic polyangiitis and PR3 ANCA in vaginals. Very important. PR3 ANCA in vaginals. What you will find now? Upper respiratory tract. You will find granulomatous sinusitis. You will find ulceration in the nose, in the palate, in the pharynx. So there will be lesions in the upper respiratory tract. All the upper respiratory tract may be involved. There will be granulomas, there can be ulcerations. And in the lungs also you will find granulomas or the diffuse infiltrates. And vasculitis will be granulomatous vasculitis. Necrotizing granulomatous vasculitis. There will be necrosis, there will be granulomas in the vasculitis. And mostly the granulomas, when they are there, they can sometimes coalesce with each other. So they coalesce with each other, they fuse with each other, and there is a central cavitation. In the center, a cavity is created. So you can detect this thing on the radiograph also. What is the confusion then? With what disease it can be confused? Any ideas? With what disease it can be? Which disease it can be confused? If you have a granulomas and it has a central cavitation. What was
TB.
you are thinking?
TB, yes.
Yeah, TB, yeah? Tuberculosis.
Even in the lung.
Because it has the granulomas, nodules with cavitation. So cavitation is produced because of the caseous necrosis in the tuberculosis. You got it? So you can be confused with that. Then destruction, when the vessels are involved, they are destroyed, then it leads to hemorrhage and hemoptysis. Is it clear? Hemorrhage along with hemoptysis because lung is involved. And lesions will undergo progressive fibrosis and organization, as you know. This is the ultimate outcome of the. And renal lesions, how they present? They can destroy the kidney. So they can present in focal segmental necrotizing glomerulonephritis and sometimes the crescentic glomerulonephritis, which is very dangerous. It can lead to death. So it can sometimes, diagnosed granulomatosis can sometimes be very dangerous. Is it clear?
Yes.
It involves the lung and the kidneys, which is the classical presentation, but it can have the limited as well as the widespread form also. And you can find the granulomas and the necrotizing vasculitis in these areas. And sometimes due to the involvement of the kidneys, it can be very, very dangerous, leading to crescentic glomerulonephritis, which is many of the times fatal. What is the clinical feature? Mostly it will present in men aged 40 years. But this is a general classical presentation. But women and all ages can be involved. So there is no rule that it will involve. But typical presentation is 40-year-old man. How it will present? Symptoms related to the lung. Bilateral pneumonitis involving both the lungs. Chronic sinusitis. Then renal disease. In majority of the cases, 95, 90 and 80%. But there can be other symptoms also. So renal disease, how it will present? If the kidneys are involved, hematuria, proteinuria or rapidly progressive renal failure, which can cause death in the person. If untreated, mortality is very high. It is 80% at 1 year. 80%, if you don't treat, 80%. So here comes the importance of diagnosing the disease. So if you are not able to diagnose in 1 year, and many of the patients are like that and doctors are also like that. The patients, they will come after 3-4 months. And doctor is also like that, he is giving some drugs, go back, give drug, go back. Sometimes the patient dies before diagnosis. Diagnosis is not there. And sometimes we diagnose on the post-mortem. The post-mortem is done to evaluate the cause of the death and we see the cause of the death. Many times this happens. So treatment, you have to do these things. The steroids, cyclophosphamide, immunosuppressive drugs, TNF inhibitors, anti-B cell antibodies. So all these things you will do. This finishes that, the Wagner's. Now comes the last one. Churg-Strauss syndrome among the small vessel vasculitis. What is the importance of Churg-Strauss syndrome? It is the allergic one. So we also call it allergic granulomatosis. So what is the other name? Allergic granulomatosis. It is associated with the asthma or the allergic disorders along with the granulomas. You got it? Microscopic polyangiitis, no granuloma, no asthma. Wagner's, granuloma only. Here, granuloma along with the, very good. So small vessel necrotizing vasculitis, again there is necrosis, there is inflammation of the vessels associated with asthma, allergic rhinitis, eosinophilia, lung infiltrates, and you will have extravascular necrotizing granulomas also. Granulomas outside the vessels and infiltration of the vessels and the perivascular tissues by eosinophils. So everywhere you will find eosinophils, everywhere. So eosinophils will be present everywhere. It is a rare disorder affecting 1 in 1 million. So 1 million you will find one patient. How it occurs? There is hyper responsiveness to some allergic stimulus. Okay, because it is allergic. So there is some hyper responsiveness to allergic stimulus. MPO-ANCAs are present in minority of the cases. So microscopic polyangiitis and Churg-Strauss syndrome may be associated with MPO-ANCA. Okay, Wagner's with PR3M. So what you will find? You will find skin involved, purpuras, GI bleeding when these are involved, kidneys, glomerulosclerosis, okay, and sometimes the heart can be involved. Suppose the eosinophils go into the heart and they release the cytotoxic material. So heart can be injured. So cytotoxicity from the eosinophilic infiltrates will lead to cardiomyopathy. Okay, and this is present in 60% of the patients, and this is the major cause of morbidity and mortality in the patients. Major cause of death in these patients. Clear? So Churg-Strauss, granuloma along with the allergic disorders, eosinophilia you will find everywhere almost, and It can have many organs involved, especially the involvement of the heart is very dangerous. It can lead to death of the person. Is it clear? So we finish the small vessel vasculitis. Now comes a very, very important disorder, which is very, very, interesting. Thromboangiitis. Thromboangiitis. If you get it, what are the features from the disease? Thromboangiitis. Throm means formation of thrombus. Angiitis, itis, inflammation of the vessels. Obliterans, they are obliterated. The vessels are obliterated by presence of thrombus. From the name, it is also known as Berger's disease. Also known as Berger's disease. So this is a disorder which is typically present in the smokers at the age of 35. Typically present in the smokers at the age of 35 years. Clear? Exclusively in smokers at the age of 35 years. Etiology is unknown. They say there are some factors in the tobacco smoke which can directly attack the endothelial cells. One. Or they can modify the vessel wall. Some of the antigens present in the smoke, they modify the vessel wall. Then your immune system responds against this. Okay? So it can be direct injury by the tobacco smoke or indirect through the formation of immune complexes. And a genetic predisposition is there because everybody is smoking almost in Saudi Arabia. But there is a genetic predisposition, and it is mostly present in the Israeli, Indian subcontinent, Japanese. Okay? You are saying? Good for them, Indian subcontinent. I am not smoking. So these things, you got it? Now what is present in these? There is acute and chronic inflammation of medium-sized and small arteries. Medium-sized and small arteries of the extremities. Okay? So extremities are involved. Extremities. Upper limb and lower limb. Okay? And small and medium. Like radial and tibial arteries, mostly. They will be involved. Now, we will see what you will find in this disorder. So there will be transmural inflammation of the arteries, small and medium size. Acute and chronic inflammation will be there. Predominantly involving the tibial and the radial arteries. In the early stages, you will find a mixed inflammation accompanied by but here what is important is instead you will find one thing, acute and chronic inflammation in the vessel. Huge, it will be huge transmural inflammation along with thrombosis in the vessel, which will obliterate the lumen and it will lead to ischemia. So it can lead to ischemia of the limb, it can lead to gangrene. So this is very important. So mixed inflammation, thrombosis and small microabscesses which are rimmed by the granulomatous inflammation, and inflammation also extends into the veins and the nerves. So this is one disorder, vasculitis, which extends into the nerves, adjacent nerves as well as the veins. Although it involves the arteries.
Yes. Only this one.
And late stage the artery and the adjacent structures are encased in the fibrous tissue. How the patient will present, it is very important. As I said, ischemia of the limbs can occur, especially of the lower limbs, and it can lead to necrosis and gangrene. So they will have to get their limbs amputated because of that. So what happens here? One is they will present with Raynaud's phenomenon. Whenever there is cold, the limbs will turn blue, cyanosed. Or if they immerse these limbs in the cold water, they will turn blue, cyanosed. This is known as, because it will cause, already the vessels are involved. Try to understand. There is cold, there is more vasoconstriction. You got it?
Yes.
So there will be ischemia. You got it? So they have to keep their limbs warm.
Yes.
Okay? So cold induced Raynaud phenomena. Raynaud's phenomena means cold induced vasoconstriction will lead to cyanosis of the limbs. In-step foot pain induced by exercise, which is known as in-step claudication. Whenever he does the exercise, there will be pain in the limbs because they require more blood now. And the vessels are already compromised, so there will be less blood. So it will lead to claudication, which is the pain during the exercise. And it will also lead to inflammation superficially of the veins, phlebites, severe pain even at rest when the nerves are involved. And ultimately what happens, first of all, it will lead to ulcerations. Because of thrombosis of the vessel, it will lead to ulceration. And finally, it will lead to gangrene or the necrosis of the extremities. Okay? ulceration can progress to frank gangrene.
In the skin, doctor, or inside, in
Hmm?
isolation, and the skin will be.
It will be in the ulceration, in the skin itself for the extremities. No, here comes the importance of diagnosing it early. If you suspect this disease, if you have a hereditary and you have the signs and symptoms referable to the limbs, what you will do? You will tell him to stop smoking. If it is in the early stage, it can be reversed. But if it is the late stage, he will not respond. Okay? So this is a very dangerous disease. If it progresses, then smoking will remain there, but limbs will not remain there. So this finishes the Burgess, and this is the last slide. Infectious vasculitis. Huh? The organisms, bacteria and fungi will directly attack the vessel wall. Okay? And it can be because of hematogenous spread or the local spread. And vascular infections, when they attack the vessel wall, they will weaken the vessel wall, leading to aneurysm and thrombosis. So this is the mechanism. This is only one slide. You want to take 2-3 minutes?
Yes,
Or-
yes.